You
Looking at
drop.
something else. I get it. One moment.
Ooh. Okay.
Okay. So I'm starting with the intro, yes?
No, I'm
But
starting.
we'll do the intro.
Oh, we're doing that again, are we?
Yeah. That was our
Okay.
practice run.
That was our
Oh,
practice
okay.
run.
Sorry. I thought we
Yeah.
nailed it. Okay.
All right. Now on YouTube.
Hey, go.
Go for it.
All right. Welcome to the Pelvic Health Podcast. Welcome back to the Pelvic Health Podcast, really, I should say. I'm Lori Forner, physio, PhD, and currently studying obstetric and gynecological sonography.
I'm Tam, pelvic health physio, educator, and total anatomy nerd.
And I'm Jo, pelvic health physio, and currently studying medicine to hopefully one day become an obstetrician and gynecologist.
We're three clinicians who love diving into big conversations about pelvic health with leading researchers, academics, and frontline clinicians from all around the world.
So if you're a physio, doctor, midwife, nurse, or educator, and pelvic health is your jam, you're in the right place. So thanks for tuning in, and let's get to it.
And before we begin, we'd like to acknowledge the traditional custodians of the land we're recording on today. We pay our respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples listening.
Done.
Done.
It's funny, it didn't say pelvic health physio for me, but we all know it's fine.
We're good.
I did wonder that when
yeah.
you said it. I was like, is she maybe? Anyway, doesn't matter.
Yeah.
Right.
You can do it if you want to do your line again. Pelvic health physio.
All right, we'll do
Good.
one
All
more
right.
time.
Okay.
Okay, one more time. I was like, am I saying welcome back? Welcome. Welcome back. Welcome. Welcome to the Pelvic Health Podcast. I'm Lori Forner, pelvic health physio, PhD, and currently studying obstetric and gynecological sonography.
I'm Tam, pelvic health physio, educator, and total anatomy nerd.
And I'm Jo, pelvic health physio, and currently studying medicine to become an obstetrician and gynecologist.
We're three clinicians who love diving into big conversations about pelvic health. What'd you do?
She stuffed
Blah,
it.
blah,
Just
blah.
fit.
Blah, blah, blah. You did not.
Go again. Yep.
No,
Sorry
she
about
didn't.
that.
She just wasn't happy with it.
This is our blooper reel, everyone. Okay. Welcome to the Pelvic Health Podcast. I'm Lori Forner, pelvic health physio, PhD, and currently studying obstetric and gynecological sonography.
I'm Tam, pelvic health physio, educator, and total anatomy nerd.
And I'm Jo, pelvic health physio, and currently studying medicine to hopefully one day become an obstetrician and gynecologist.
We are three clinicians who love diving into big conversations about pelvic health with leading researchers, academics, and frontline clinicians from all around the world.
So if you're a physio, a doctor, midwife, nurse, or educator, and pelvic health is your jam, you're in the right place. Thanks for tuning in, and let's get to it.
And before we begin, we'd like to acknowledge the traditional custodians of the land we're recording on today. We pay our respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples listening.
Lovely. All right, we're going to do that live every time, guys.
To change it?
Yeah, totally. Let's do it. We're new. We're back and we're new.
It would actually be quite fun.
Yeah.
All right. Intro for this AM. Got it. We ready?
Yeah, we're ready.
Welcome back, Dr. Lori Forner, for part 2 of your interview on your own podcast, of course. In part 1, we learnt about your motivation behind starting your CrossFit and your PhD. You walked us through your first massive cross-sectional survey of nearly 4,000 women, which challenged us all, that's for sure, on our clinical assumptions about lifting weights and risk of pelvic organ prolapse. You then shared your insights about your unpublished data on pelvic floor dimensions using PopQ and 3D transperineal real-time ultrasound in lifters versus non-lifters, which again basically highlights there is no difference, challenging our now old beliefs that lifting heavy is bad for your pelvic floor.
And we were loving it so much, and we know that you've got so much more to share. So we're back to ask you a whole bunch more questions. I thought first we might pick up on your points around the changes of pelvic floor assessment from supine to standing that you mentioned in part 1. You've written a few papers on the changes that happens with the pelvic floor according to the position you're assessing them in. So I feel this might have real clinical implications for us. So can you please talk us through those studies and how you think we should be using that information in our clinics?
Definitely. Now, as soon as I have to talk and I get nervous, I've realized that's my tick. Having
That's your
to
cough.
clear my throat all the
Cough.
time. Yeah, and my hands, sweaty hands, guys, sweaty hands. Look, as far as I know, and I'll double check this, I think my thesis is now published. So those unpublished
It
papers that I was
is. It
talking
is
about,
confirmed, published. Have seen
how do
it.
you know? Did you look?
I saw it
So,
online.
oh, no way. So wait a minute. So you can go see those 2 papers that I was talking about that aren't published in a journal article.
Oh, we could
So
too.
they're
Yes.
published. Yeah, so they are in there,
Yeah.
so people can read
Ah.
them. They're just
How did
not
you
in
find
the
that? I tried to find this. I could not find it. No, you just found it. Okay.
Googled.
Mm,
Googled, ask
mm,
ChatGPT,
mm,
tell you
mm,
everything.
Okay.
Yes, so the 2 papers that you're talking about. So if we follow on kind of from last time, we were talking about one of the subjective papers we did about who are the people that are reporting that presence of pelvic organ prolapse. And even from here on in, we used the sensation of a vaginal bulge or lump in the vagina as our subjective indicator of whether or not someone has pelvic organ prolapse. So the descent of bladder, cervix, bowel, and that definition has changed since we started this research. So remember, this was like 8 years ago. Um, there's been a lot of research around what constitutes pelvic organ prolapse, and we know how long it can take research to kind of get into the public space. So some of this
Mm.
was even around back then. But essentially now with some of our recent guidelines that the definition of pelvic organ prolapse has to include subjective complaints. So yes, someone can have descent of their bladder to the opening and they don't feel it. Objectively, it's pelvic organ prolapse, but pelvic organ prolapse is really based on someone's subjective complaints and how much it bugs them as to whether or not we actually address it, I guess, surgically, because as physios, we're going to address everything. So within our studies, we used, if we're saying that a group had pelvic organ prolapse or not, we were using it as in they had subjective issues, so they could feel that sensation of a bulge or a lump if we just use subjective, because there's other questions we can ask, low back pain. But that one in the research is like really tied to whether objectively or not they have something that's kind of at the surface of their hymen. And if they objectively had prolapse, we're using that stage 2, right? Which when we do a pop Q meant it was within a centimeter of the hymen. So it's just a centimeter inside at the hymen or a centimeter outside on bearing down and straining. But what I did was really try to define that a little bit more. So if we objectively looked at women that had prolapse, so the sensation, I tried to make a cutoff, at least in the later studies, that it had to at least be at the hymen, so 0
Mm.
centimeters, because we know that there's a subset of people that don't have symptoms and they have a little bit of movement and descent. I think for a long time we thought any movement was prolapse. And we would scare the crap out of people because we would assess
Mm.
them bearing down and they'd have a little bit of movement. Stage 1, right? Bunny earring for those listening, stage 1. We'd be like, oh God, you have pelvic organ prolapse, and now you need to do all this stuff. And then it just made people really paranoid. It's soft tissue, it is meant to move. Some people move a little bit more, some people don't. So that definition over the research time changed a little bit. So how we kind of did the research over time changed a little bit. So after the subjective papers we did, we then started looking. And this is where, again, my research kind of took a turn where I'm glad it went. We got information, but the majority of the time was spent on this, and I wanted it to be spent on the end products of the heavy lifters. But we looked at okay, if we're going to, and I think I discussed it in the last podcast, right? If you really want everyone to start in the same position to work out if something's causing a difference, then you want everyone to be at the same baseline. And that would
Mm.
be measuring people before they got out of bed in the morning, which isn't
Yeah.
going to happen.
Yeah.
Yeah.
So as soon as you're upright and gravity takes hold, different parts of your body do different things, and everyone's going to start at kind of a different spot. And it may not be their baseline, right? Because they may have just dropped their kids off to school. They may have coughed a few times in the morning to clear their throat. They may have a nervous tick. So everyone's going to be at a different spot. But the question was, well, has anybody studied that? So let's go have a look at it, right? You're like, damn it, fine. Good
Mm.
question. So that is where that paper where we had everybody lie down for half an hour, right? And we went, okay, let's get everyone in and they'll lie down for half an hour and then we'll reassess them. And we'll see if lying down for half an hour kind of resets everyone's system. And it was in that time I was using ultrasound and I'd started using ultrasound in the clinic. And I was noticing that if we measured people in supine and we measured people in standing, it was very different. And I went, okay, we need to use both. So let's measure with ultrasound. Uh, at rest, I also thought was an important measure that wasn't looked at in the research a lot. We'll measure them bearing down, which is the main thing that's in research, and we'll measure pelvic floor contraction. And we'll look at where their organs are in those tasks in supine. We'll look at them in standing. We'll have them lie down for half an hour. We'll reassess. And I decided the best people to look at that was the people who had descent and extra movement, right? So people who
Mm.
had complaints of pelvic organ prolapse. So we took about 20 people just to kind of test it out. And in my mind, I went, we're not really going to see a difference. Like half an hour lying down, as soon as they stand up, it's going to go back to where it was before.
Mm.
And the big question that when we were doing our peer review process, even in my PhD discussions at the end, were why'd you pick half an hour, right? Yeah, 8 hours would have been great. An hour would have been great. But at some point, you got to cut it off thinking we need these women to come in. These are
Mm.
all women that have had a vaginal delivery, so they've got kids that they're taking care of. Like at some point, you need to have some sort of cutoff. And we chose half an hour because with the assessment, the amount of time people would have to come in, it just seemed more feasible and logical. Also, if we found that this lying down for half an hour was really good and made changes, we need to be able to use it in the clinic.
Yeah.
And the amount of time we have in the clinic is also limited. So I went, let's do half an hour. So
Good
really,
decision.
thank you. Thank you. Again, rambling. Blah, 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 blah. So we used half an hour, and really, when we're looking at kind of does half an hour make a difference and change things, it didn't. What
Mm.
we found in the research was in supine, especially after that half an hour resting, the levator hiatus, so the muscle surrounding the hiatal area, was actually a little bit more distensible and more relaxed. And I
Mm.
don't think it's because of the lying down. Remember, we did pop Q, we did supine, we did standing before they lay down, and every one of those were bearing down
Mhm.
a few times. Bear down a few times in pop Q, supine. Bear down a few times in pop Q for ultrasound. Bear down a few times in standing. So I think what happened was that I don't think we stretched tissue. I think people were just able to get the concept of letting go, relaxing, bearing down. Then they
Mm.
lay down and relax. And then the first measurement we do afterwards is still in supine. That I think they were just able to let go
Mm.
better. And we talked last time about people with prolapse, unfortunately, are very good at letting go and bearing down.
Mm.
Yeah.
So essentially, like I said before, I wanted two papers in one. This is the same thing. This paper and the next one that followed, measuring the difference between supine and standing, I had initially planned in my mind to have that combined because that supine paper didn't have a lot in it. Whereas when we compared supine and standing, that was where we saw a lot more of the differences. So we ended up then taking those. Oh, actually, I can't remember if we took the women. Yeah, we ended up comparing those women with prolapse against some of the women that were from our lifting study who had no prolapse or prolapse symptoms. And we compared the differences in when we measure supine versus when we measure standing and comparing between women with and without prolapse.
So where should we assess them? Supine or standing?
Well, I think we
Or
need to do
both.
both. I think we need to do
Or
both,
both.
right? So
Mm.
in research, if we're going to compare against other research, pretty much everything is done in supine, right? And when we look back at the research, in part, it is easier for the patient. It's way easier for the clinician. The bearing down maneuver, and thanks to Joe and Tam, that is what I call it now, right? Instead of Valsalva, but you're still going to see Valsalva in all the research. We know as exercise physiologists and physios, Valsalva is different than bearing down, but when you're a gynecologist and a doctor, it's not. So
It
we
will
call it
be
bearing.
one day.
It will be one day. We call it bearing down. We want them to relax and let go of their pelvic floor as they're pushing down, right? We will get into their research in another episode. So we had them lying down. Wait, and now see, look, now I just forgot what we were talking about. This hasn't happened in a while.
Where should we assess them? I
Thanks.
think is where it was.
Thanks,
Yeah,
guys.
yeah.
Yeah. So you want to assess supine. You want to be able to compare to different research that is out there. The bearing down maneuver is used so that you can simulate the effect of gravity, right? Um, they say if someone has levator co-contraction when you're bearing down, or if you can't see the extent of what they're complaining about, then you should use standing.
Mm.
And in some of the research, standing, again, is more, they'll say it's more awkward for the person doing it. But as physios, we try to take everything and make it functional, right? And real life scenarios. Well, especially when we're talking about exercise, we're not talking often about lying down. There's a lot of exercises lying down. We should look at lying down. We should look at lying down because it gives us an idea of where things might rest when they're lying down. If they're going to do lying down exercises, we can still use that bearing down maneuver. If we're talking about labor and birth and people might be delivering in that position, it's a great position to do it in. But if we want to be as functional as possible, we really need to look at standing. And I thought a big part of what I had learned, especially, I found it very hard to separate academic hat from clinical hat because academics like to stay in their bubble. And I kept going, yeah, but what about like, well, but we do this. And they're like, no, stay here. So I kept thinking, but when you stand at rest, right? And I'm not meaning standing and letting go of your pelvic floor, just your average normal standing, not thinking about things as rest, because we know things are on. That position is what your kind of body is in and using for most parts of your day. Yes, pelvic floor works different when you're speaking and talking and lifting and, pulling a cup out of the cupboard, but that resting position I think is really important. So that was one of the things I got at it as a clinician was we really should be looking at standing rest. We can look at standing bearing down to go, okay, if you're doing some type of activity that you're putting pressure, how well does your body cope with that standing? And I think putting pressure and also seeing how well they can let go. Because again, some people will co-contract and we can't change that. And we can try to cue them. And the whole point of trying to change co-contraction is to go, well, if their muscles weren't there and super fatigued, how far down might all of those organs descend? But if you can't get rid of the co-contraction, I always tell my patients, awesome. Because your body is like, I don't want to let go. And you can't even get rid of that by thinking about it. Great. That's exactly what we want. Right. And then having a look at what happens when they contract their pelvic floor, because at rest, things might sit low, but when they contract, it gives them this great support. We can use that. And then in standing, we can get them to do some different activities and see how their body reacts to it. So I thought from a physio point of view, wow, standing gives us so much information, especially using ultrasound, right? But not everyone's going to have access to ultrasound. There's a whole rural portion that we haven't talked about that may not even have access to physios, and that's where telehealth and online health comes in. So we may not even be able, I have children, on Monday morning trying to annoy me, sorry. We might not even be able to physically assess them. So we need to find different ways to be able to help these women. And that's where I think those kind of 2 studies and 2 papers took my head as a clinical brain.
If they do happen to have ultrasound, a physio in the clinic, it's usually 2D transperineal. and I mean, it's a skill in and
Mm,
upon itself to be able to get an image in standing, let alone look at anything in particular. But if they happen to have this ultrasound in
mm.
standing, looking at someone, what measures or what should they be looking at? What would give them the most information about the support of the pelvic floor, for example, in the clinic?
Yeah. Look, and I'll start that off by saying, so 3D 40, I love. 40 is
Mm.
just time. My husband's like, is it smell? Is that the fourth dimension? I'm like, oh my God. No. Fourth dimension is time. So seeing things in real time,
Uh,
which in a 3D kind of environment, right? So when you take those little cine loops, that portion gives us access to looking at levator avulsion,
mm,
levator hiatal area. It
mm,
is a really important part, but again, the access to that type of machine is like, 150,000, or like it's the chances of, and if you unless you're working in an obstetric clinic, and actually a lot of obstetricians don't even have the 3D portion of it too. So that's kind of what we miss with the 2D, but using 2D, that's where you get to see, okay, well, where's the bladder sitting? Cervix is a lot harder, but one day we'll earn our eyes, right? So we'll be able to see where the uterus and cervix is, where the rectal ampulla is. So it's just kind of where that rectum before it becomes the anal canal. And you can see the back portion in a two-dimensional view of where
mm,
levator ani is, that medial portion of where levator ani is. So you can look at those different kind of landmarks against a random horizontal line from the pubic symphysis
mm,
as like, okay, where are these structures sitting above, at, or below, at rest, on squeezing, and on bearing down? But again, as physios, yes, we want to look at static position at those different tasks, but we really want to know, well, what happens while we're doing different activities? What happens when we breathe? What happens when we're, how much can we control that contraction? What happens if we're holding our baby? What happens if we lift some weight? So we can use those different landmarks in a dynamic way as well.
mm. Amazing.
Yeah, very fun. That's a great clinical perla, I think. And I think it's always that thing of just giving it a crack, isn't it, in the clinic when you're first
Mm,
learning? um,
Yeah.
just even the thought of putting an ultrasound probe on someone's perineum in standing
Yes.
is a
Well,
barrier.
and so that's when I teach courses, and so do you
mhm,
guys, on how to use transperineal ultrasound for physiotherapists. And the best way to start is just do it supine. Don't even
mm,
take
Mm,
measurements. Just start to look. Get people to cough, get people to contract. Don't measure anything, but just keep using it. Try to find a straight centered position and just observe, right? Show people, use it as biofeedback. It's perfect for biofeedback to be able to show people what's happening when they squeeze. They see things move and they're like, oh, it's the inside of my body.
mm.
And once you're used to all those things, then you can attempt standing.
yeah, very good.
But I do think that
Excellent.
the use of ultrasound, especially 2D in our world, at least in Australia, has increased dramatically. But I
I think
Mm,
know,
so.
like Grania Donnelly in the UK, she's got a course on teaching it, and she travels around teaching it. And I think the accessibility is increasing because a lot more machines are getting a little bit cheaper because they can be handheld. So I think our
Yeah,
utility is going to skyrocket,
yeah,
which I think is
that's
really
right.
cool.
Yeah.
Yeah.
And then it's just learning to look at the landmarks, like you said. Look
Yeah.
at it, look at it, look at it, look at it. And then you start to see differences. Mm.
Yeah. Yep.
excellent. The other interesting study that you did was comparing runners and CrossFitters, which I thought no doubt would be very interesting for this audience as well. What did you find in that study?
Should have read that before we started, shouldn't I?
So should have I.
Yeah, yeah, no. Look, this
Did you read that
was,
one, Tam?
I did, but I can't. I'm just looking at my little
yeah, I'm
blurb
like,
of it
okay, hold
now.
on, let me pull it up. Look, from memory. The reason I did this, so this was always a question I had as I was delivering all these talks at conferences and online because COVID had happened, I kept having this question about, okay, we did the survey study of all these different people doing exercise, lifting different amounts, who has that sensation? And remember, I said, if you listen to the last episode, if you haven't, go listen, that there was a time where running was not okay, lifting weights was not okay, because they both put pressure and could cause pelvic floor issues in women who were potentially at risk, which was everybody. Then I don't know where or why, but in Australia, I started noticing that running was okay. Doctors were like, you can run, but no lifting weights. And I'm like, oh, that's interesting. And I just slowly kind of noticed this acceptable standard of running not being the absolute enemy. And I'm like, great. And I think, and it's so just my opinion, parkrun became very popular. And all these people just started enjoying this community based short running program. And I always think, and it's only based on my experience, is that as a clinician, when you are involved in certain activities, you enjoy it and you're more likely to maybe not recommend it, but you're less likely to tell people not to do it because you like it and you found it fun and enjoyable. So I was always like, all of these health professionals are probably doing park run and they're like, yeah, you should do it. It's not that bad. Or I
I
don't know where it came from.
I reckon as well the women would run anyway, like your patients
Yeah.
that run anyway.
Yeah.
And so
Yeah.
then they're coming back to their health professional and the health
Yeah.
professional's realizing that they're absolutely fine. And so
Yeah.
probably
Yeah.
you can run.
Totally.
Mm.
And it's free. It's easy. You have a baby, you can run with a pram. Like you don't need to get someone to look after them. Like I think again that accessibility was really helpful and it's a community-based program. You're out with talking with people. So then I started to have that question of, well, if we're okay to run and that causes pressure and there's ground reaction forces, but we're not okay to lift weights, well, why? So I'm like, nobody's doing, okay, we need to ask that question. Can you, what's the difference between people who run but don't lift any weights and people who lift weights? And it wasn't people who lift weights and don't run. It was actually people who lift weights and run, right? So, um, and that's we'd already had all of that information. Remember, greater than 4,000 people. We had all these, women who were lifting weights, participating in things like CrossFit, which includes kind of short sprints, not super long runs. Every once in a while, they might do some sort of run. So the real only difference was the load, right? So I think there was about maybe 858 women lifting greater than 15 kilos because that was our previous cutoff. And then maybe 500 something runners who don't lift more than 15 kilos. So it kind of split
Right.
them up. So still just subjective. Out of those 858, I think there was a very large percentage, like greater than 50%, who could do more than 100 kilos for their deadlift. So they were still lifting a significant amount of weight, right? Or they could lift a significant amount of weight. And then
Mhm.
we went through not just the sensation of pelvic organ or not just the sensation of a vaginal bulge. We actually went through the whole PFDI 20. So the questions on stress incontinence, the questions on stress and urge incontinence, all the questions based around prolapse, and then the colorectal distress. So anal incontinence, gas, all of those things. And we could compare that between all of the groups. And essentially, and then I had also broken it up into, in a general sense, what were all the differences, but then also how much of a difference did it make if you had a vaginal parity, like if you'd had at least one vaginal delivery. So really what we had found was that runners seem to have more of a prevalence of reporting symptoms for leakage of, so anal incontinence, which included gas and solid stool, but the
Mhm.
highest proportion was gas, the leakage of gas, right? So when you're running, I don't know if anyone's ran and just kind of farted while they're running. Happens. Even if you have the best pelvic floor, it happens. As well as the sensation of a vaginal bulge. And of course, if you had vaginal birth, your report was higher. So I was very big in stressing it doesn't mean that running is worse or lifting weights is better. I'm just trying to show that people who are lifting weights aren't saying that they have more symptoms than people doing this activity. It's not vilifying running. And when we looked at the prevalence of pelvic floor symptoms, it was still a lot lower than the general public. Like we're talking 15%, right? Like it's not a high proportion, but it was higher than the group that was lifting. What we did find that was very interesting is when you look at stress incontinence, right? There actually wasn't a difference between the two groups. Remember, though, all of these CrossFitters also do skipping and double unders. And double unders means you jump higher vertical distance to get the rope under twice. So you have a heavier ground reaction force than if you're running. So, not surprisingly, that when you then kind of almost separated it, it wasn't statistically significant, but you can see that the CrossFitters actually probably had a bit more stress incontinence than the runners. And unfortunately, in the survey study, we used the specific wording of do you leak when you cough, sneeze, or laugh? It didn't say, do you leak when you exercise, which we presume people would know. But actually, some of the comments at the end of the survey was, I ticked no because I only leak when I run. And I went, damn it.
Damn it.
So I know. So, I mean, we take that how we
They
can,
were reading
right?
the questions very well.
Reading the questions very well. So
Making no assumptions.
No.
yes, and our conclusion was again, lifting heavy weights, CrossFit isn't worse than that activity, as opposed to saying, you know, if you run, it's bad. If you do this, it's good. But yeah, it was a great little subjective study before we went into our objective information. And I'm sorry for anyone hearing the pots and pans, as my husband was
I
said.
can't hear him.
Yeah.
Oh, good.
Yeah.
Okay. All right. I hear him. It's very loud, but he's my cook, so can't complain.
Love it. Joe, did you want to ask something about the Delphi study as well? The
I was
postpartum?
no,
she's
no,
no.
I don't.
We
I
do
definitely
not. We do
No,
not want to ask
not
anything
interested.
about that.
We do. No, look, it's only
No.
it's an absolutely brilliant study, and I will point people to it, and maybe we'll have them come on the podcast to talk
Yeah,
about
fair.
it because I wasn't first author on that study.
Oh,
No, I
fair
get
enough.
it. Yeah.
And you
yeah,
can
yeah,
see
yeah.
how hard it is sometimes to remember studies you've conducted
Details.
yourself
Yeah.
and written, that then actually talking about a study that I was involved in but not running. My memory might be really bad. And we don't want to do it disservice. So we'll have the main authors come on and talk about it.
Good idea.
That is fair.
Sorry.
Did you have anything else to ask?
No, I don't have anything else at
Yeah.
this point.
I have one,
don't
but you
think.
don't
Do
have
you?
to answer it, Laurie, because it might be touchy. It's more about what, because I would never, and I mean, you're doing research too, Joe. So you're both in the research world. I personally don't think about doing research. And so therefore, get confused. No, we're going to edit that part out. The question is, if someone was thinking about wanting to do a PhD because, like you, they have a question that they want answered and they're looking to get into that world, what would you tell them? Do you have any advice for them before deciding to start down that journey or you know, deciding to do it? Hard question.
I'm not frozen, by the way.
You cannot answer it.
Oh, I can. Oh, look, you know what? People ask me this all the time. We need more research. We always need more research. I just think picking the right people as your team is probably the most important thing.
Do you get to
need
pick?
the right people.
Do you get to
Well,
pick?
look,
You do.
I
Yeah.
don't know how it works everywhere else. I got to choose, but remember, I don't even think we, got into it. How the team that was the original team did not end up being the team that we finished with. So much changes, and your ability to adapt to all of these changes and especially a lot of changes that not only do you not foresee, but you don't plan on and maybe don't want, and you still have to push through. But I do think if you have the people who are in the same field, who have the same passion as you, that will be what makes the biggest
Mm.
difference and the best way to go about it. But I love research. There was just
Mm.
a lot of the politics and policies around it that, again, allowed me to discover the joy of Lexapro.
And
Mm.
did it allow you to get an answer to the question that you started off wanting to know the answer of? Does that make sense? What did you learn? What was your biggest take home learning through your
It was
PhD?
always about the journey. I could care less about the letters. Again, on the social media and part of this, I'll have written Dr. Laurie Forner, but that just feels weird. And it was never the reason that I got into it.
Mm.
I wanted to know about whether or not women participating in heavy lifting activities really damages their pelvic floor. And so the not necessarily the studies that were published and the findings that we had, in a general sense, we could see that for most women, or for a lot of women, it doesn't negatively affect their pelvic floor. But that's a big caveat. And I think I talked about it earlier, but we weren't recording
Mm.
that. A lot of people have taken that on social media. You can see the change in the promotion of doing this as an activity. And we know from a general health point of view, it's actually really necessary. As soon as people go through menopause, our bone building abilities, peak by the age of 25. We might start to lose a little bit of bone in menopause, especially when changes with hormones and estrogen take place. We might lose muscle mass. We can lose bone density, things like osteoporosis, osteopenia. We know from the research that doing heavy loads and progressing to heavy loads is actually really important for our bones and bone building prevention, but also treatment of things like osteoporosis. So it's a necessary activity. And like I said, for women who don't have the symptom of pelvic organ prolapse, that have had a vaginal delivery, of the population, that very specific population that we looked at, that it didn't negatively affect them in the time they were doing it. We're not measuring them 20 years down the road. We don't know any of that information. We know as physios, we can use pessaries to potentially um, give that scaffolding and preventative, possibly. Again, we don't know, but it's like wearing an ankle brace, sort of giving you some
Mm,
support to be able to
yep,
do
definitely.
those exercises. We know that some women can do this activity and it's not potentially negatively affecting them. But there's a whole section of women that haven't been studied, but also as a clinician, we have to be weary of. They need to do this exercise for their health because it's better to not end up in hospital from breaking a hip and potentially dying, as opposed to having your organs hanging out. Um, but say, like that example I gave in that first episode about my patient who was in her 60s, who had bilateral avulsion, who loved working as a volunteer in the ambulance service. Somebody like that, where they've had the surgery, we know if you're going to have a second surgery, your chances of it being successful are even less, right?
Mm.
Somebody like that may never be able to actually lift heavy weights. And we have to be very careful. We can't have that blanket approach like we had about not doing it. We've got to be very careful about a blanket approach about everyone can do it. Lori has showed with her research that it doesn't give you prolapse. These are the things of the way that people are wording it, right? Anyone can heavy lift. Don't listen to all those people. It's like everybody is really different, and there are going to be people that can't do it. They may only ever be able to do some light bench in a declined supine position where everything is like really supported, right? Generally lying down with sit-ups are less pressure than standing alone, but some people just don't do it very well. Some people just don't have that support. And unfortunately, with avulsion, we don't have a treatment fix for that. So I think I just want people to be very careful, especially those who are not physically observing patients and how they can do these activities in the moment and how it changes over time. I think we need to be very careful about this information that we now have.
And I
So
think
yes,
that's
it's sort of
where,
answered the story.
Love it.
no, I think it answered it very well. And it
Mm.
kind of, it draws on your point around upskilling in transperineal ultrasound if you can, because, you know, you can use it in your assessment, but you can also use it in designing that load, can't you? Like, okay, well, let's just see how much we think you can handle or how much your pelvic organs can handle by assessing it whilst they're doing an exercise or under a certain amount of load. So, yeah, it's excellent.
And again, I think you can use the ultrasound. It's especially useful for the people we're trying to prevent things from worsening, right? Where it's not even at the hymen or it's at the hymen. Because remember, hymen is not where the labia touch. So just observing from the outside, like obviously external labia, but internal labia, it's not necessarily, you may not be able to physically see it. Yes, you might be able to feel with your finger. It does get a bit awkward, but I don't think you can do every exercise with your finger up there. There's a lot of people who don't really want to do that. And they're not going to be doing the exercise exactly the way they probably would do it if your finger wasn't there. So,
What?
I mean, if you, there, I don't know if that was just my son. Um, so yes, it's really helpful. I think like if someone's got a stage 3 where it's kind of hanging out, you could pretty much visually observe changes in how well you might be, again, using a pessary, being able to visually observe. But those kind of, lesser positions up higher into the pelvis, I think the ultrasound's even more helpful for.
Agreed.
Brilliant. Game
Do you have
changer.
anything else you want to add, Laurie? I feel like I feel like that was it. You added it all. But I
Yeah.
thought I'd
Added it
ask, as
all.
you
It was
always
like
do.
almost a decade of um work that I'm happy to move on to. So maybe that's just the last thing is that all of that also, in the beginning, that team that was different. I was never doing the ultrasound. I was never meant to be doing the ultrasound. And because of things out of my control, I had to very quickly go and learn to do transperineal ultrasound. But this is why the journey is amazing. All these things that happen that are out of your control, some are absolute shit. But some are amazing that totally change your life, right? Like now that
Yeah.
I'm through all of that, it led me to finding ultrasound. And now I am slowly leaving my clinical patient interaction as a physiotherapist behind me. I didn't renew my insurance as a physio this year.
Oh,
No.
That's a big
I am still
step.
opera registered, but yes, I
yeah,
did
got it.
not renew because now I am doing my graduate diploma in obstetric and gynecological sonography so that I am now scanning lots of pregnancy and lots of babies, but also my passion of the gynecological ultrasound, which is very interesting because transperineal, the way that we're talking about it and my PhD, it's also not a sonography thing. It's a urogynecology thing.
Mm.
So the sonographers
Right.
don't look at avulsion. They don't look at levator hiatal area. They don't even really look at prolapse. Some of them do, but not a lot. So
Mm.
hopefully I can bring that into that field
Oh,
a little bit more as
fantastic.
well. Yeah. So, but we do a lot of scanning for endometriosis.
Mm.
And
Very
again,
cool.
working with a lot of patients with pain, which would have been another PhD idea that I'd had initially, but I was like, pain is so complex. There's no way I can take any of the subjective stuff out of it, even though that's a lot of what it is.
Yep.
Um, And we, did that PB conference a couple years ago on that side. We had Jackie Chua, who's one of the owners of Queensland Ultrasound for Women. Shout out my work. Woohoo! UFW. It is a wonderful area, and we'll have some people come on the podcast discussing using ultrasound for looking at things like endometriosis, because the tech is just getting so absolutely brilliant. So I'm excited to be in this space, just in a very different realm.
Love it. Well,
Brilliant.
congratulations on manipulating all of our minds and for everything you have achieved.
Yes, well done, Laurie. Looking forward to our
Thanks,
next episode
guys.
with one of your colleagues to talk about visualizing endometriosis under ultrasound.
Yeah, we'll have a few of those, because again, there's just, like I said, there's some really interesting information coming out on all of that. Well, there's been lots of research that's been out on it for a long time, but there'll be lots more as well to come.
Love
And we're
it.
back.
Yes.
We're finally back after our hiatus.
We're back. Woohoo. Good
Woo!
work.
Done.
Well done,
All
team.
right. Thanks, guys.
Yay,
Thank
that was
you.
awesome, Laurie. You really have done very good. Very, very, very good.
So
Good
much
job.
work.
I know. I
Much
can't
work.
imagine. Yeah.
So much
Yeah.
work.
And now I don't need to be interviewed anymore. This is great.
Oh, I
Job
dare
done.
say you will get asked.
Oh, yeah, maybe.
Yeah.
Maybe.
Yeah, on other podcasts.
I feel like now that you've opened up to talking about it,